The One Big Beautiful Bill Act is going to fundamentally change health care. A bipartisan group of Minnesota legislators talked about what Minnesotans might expect at a recent State of Reform Health Policy Conference in Bloomington. This is Hospital Matters, a podcast from the Minnesota Hospital Association. We're having conversations about issues impacting hospitals, health systems, and patient care in Minnesota. I'm Tim Nelson. In this episode, we're again making a change and bringing you a full-length version of a panel discussion at the recent State of Reform Health Policy Conference held in Bloomington in September. Minnesota Hospital Association Vice President of Government Affairs Mary Krinkie hosted the event. It featured DFL State Representative Steve Elkins of Bloomington, DFL State Senator and family medicine physician Alice Mann of Edina, Republican State Senator Paul Utke of Park Rapids, and Republican State Representative Danny Nadeau of Rogers.
Okay, everyone, my name is Mary Krinkie, and I am with the Minnesota Hospital Association, and I'm really excited to be able to be here today. Woo, buddies over there. Let's try to have some fun in this panel discussion with four of our state legislators here today. I've been thinking about my opening comments, and I wanted to just say I have two qualifications in legislators that I like, okay? And it doesn't have to do with whether they're male, female, House, Senate, Republican, or Democrat. My number one criteria, if I like legislators, is do they work? Okay? Do they work? That's number one. And I want you to know that all four of our legislators here today work really hard. So that's the first criteria. And the second criteria is, do they work on issues that are important? And I have my biases, but I actually think that healthcare is very important. So I am going to let each of our panelists introduce themselves, and I told them I was going to ask, I would like for each of them to share one issue that they've worked on over their legislative careers. I do want to add that we have a substitute today. Representative Bierman texted us earlier today, and he is out ill, and he found his own replacement quarterback. And just like last week, you know, did quarterback Wentz do a nice job for the Vikings? Okay, so I am very confident that State Representative Steve Elkins, who is from Bloomington, doesn't live too far away, so he is our draft pick today to join us, okay? So we're going to start out with Steve, and everybody tell a little bit about themselves, introduce themselves, and maybe one or two, Representative Elkins, not too many, one or two issues that you have worked on at the Capitol. Thank you.
Okay, works. Steve Elkins, I represent the western half of Bloomington in the Minnesota House, and I work on a lot more than one or two, so I'll just, for this audience, observe that I'm an economist by education. I've spent the last 25 years of my career managing data, and the last 10 years of that were in healthcare informatics, and spent the last 7 of those 10 at Optum Technology in Eden Prairie. And I work on lots of different issues, but the ones you would care about is I work a lot on healthcare policy, especially a student of the pharmaceutical value chain, trying to reform that. It's probably the most complicated issue that I've ever worked on, and that includes data privacy, which I spent 6 years getting past. So let's leave it at that. But I'm known as a wonk, and including healthcare policy wonk.
Thank you. Senator Mann.
Good afternoon, everyone. I'm Alice Mann. I represent Bloomington and Edina. I'm also a practicing physician, so I spent most of my time in the healthcare space. Things that I've worked on recently would be establishing the Minnesota Medication Repository Program and also establishing the Minnesota Rare Disease Advisory Council.
Great. Senator Utke.
Thank you. Paul Utke. I represent Senate District 5 up in northwestern Minnesota. issues over the years. There's been a lot of them. One that keeps popping its head up that, again, we had to work on this last year, and it's something that's very important to us, particularly when we, coming from the rural area, we talk about it a lot, but the reinsurance issue, which is a big part of healthcare and people being able to afford their insurance. And we know that's just one piece of many pieces that affect it, but that's one of them.
Thank you, Senator. And closing us out is Representative Nadeau.
Thank you, and thank you all for being here, and I appreciate being at the table here. I'm Danny Nadeau. I represent Northwest Hennepin County, Dayton, Rogers, Champlin. I serve on the Health Committee, and this year probably one of the biggest things that's going to be impactful in this room is I worked on the directed payment bill for hospitals, and we got that. Yeah, we got that pushed through. We'll see if CMS approves it, and whether or not they're going to fight between an establishment date or an enactment date, and we'll move from there. But the other thing that I wanted to bring up is a bill that I've worked on that didn't get a hearing this year that hopefully will next year, and that is basically looking at our basic health plan in Minnesota and possibly converting that to a qualified health plan, which will help provider reimbursement rates. It will expand some of the risk for our plans. We're the last state that has a BHP, and I'm working with DHS right now on kind of the technical aspects of that.
As you can tell from those introductions, they really are working on a broad range of topics, and these are 4 of the hardest working legislators at the Capitol. So first of all, I want to thank them for their public service and thank them for coming here today. So thank you to all 4 of you. I thought we would start out today with not too much fireworks, but start with a topic that really impacts everything we do in healthcare, and that is workforce. And I know you all know the statistics, but we just got some information from DEED, and I want to share a little bit with you all today. Minnesota has approximately 120,000 vacancies right now in the state. 24,000 are in healthcare, and 6,000 are at hospitals. Recently, Becker's just released that 1 million nurses will be retiring in 2030. That's not that far away. That's 5 years from now. They're not retiring because they hate being a nurse. They're not retiring because of low pay. They're not retiring because of COVID. They're not retiring because of burnout. They are retiring because they are getting old, okay? They're getting old, okay? So what we have to think about now is, are the current workforce development tools that we have in place, are they working? And what else should we be doing in the workforce development space? And then I'd actually like a follow-up question with that on AI. And can AI help us stretch our workforce if at all possible? So why don't we start this question at this end, and the next one, Danny, I'll start down there with you. So take it away.
Okay, so we need to improve our training capacity, and Normandale Community College is in my district, and they are expanding and their facilities to support both their dental programs and their nursing programs. We need the same kind of things, especially in mental health. So everybody agrees that there's a severe shortage there. We need to increase that pipeline, and in that one, we have to increase the pay as well, so people actually want to do it. I think we have a consensus that we need more mental health professionals, and we need both the bandwidth to train them and the compensation to make people want to do the work.
Thanks, Mary. I think we do need to talk about graduate medical education. We need to fund those spots and expand those spots. And I think what we're going to see now is, because of that student loan cap, we're going to see less people being able to go to medical school and these graduate schools. I cannot tell you how many phone calls I have gotten from college kids saying, kid you not, I don't know if I can go to medical school anymore. That was my dream. I can tell you that and student loan repayment are big deal. Student loan repayment works, and it works to get people into rural areas. I graduated medical school 20 years ago with $231,000 in debt. That was 20 years ago. And I had some student loan repayment, and because of that, I lived in a very rural area that served 1,000 people. That was our entire town, and I was able to work there for several years because of loan repayment. And so when we do away with these programs, like the federal government is proposing, we are going to see an increase in shortage, and I'm very concerned about that.
And I think when we talk about this topic and others, it's an all-of-the-above approach because we do have everything from the student loan repayments to, in a lot of cases, it's going in and that grow your own. It's planting that seed when these young people are probably middle school age and early high school, and it's to get them interested in all phases of healthcare. But then we need to figure out how to basically kind of shepherd them, because if I was sitting in front of a totally different audience, they're going to say they're going to try to grow their own too. So we're all fighting over a smaller pool of employee base. And so we've got that. And then, some of it's too. Mary mentioned the fact that they're retiring, and I just was out in North Dakota last weekend, and couple of my classmates recently retired as being nurses, and one of them said, well, I am back working a couple days a week. In all industries, again, that HR person is becoming more and more important, if they weren't already one of the most important. But your workforce isn't going to be all full-time employees. We're going to have to hopefully get a few more years out of some of those that have retired from full-time, and now let's bring in 2 or 3 of them to cover that weekly shift. It's all thinking outside of the box, and it's being concerned about the industry and making sure we've got people to fill those spots 10 and 15 years down the road. AI, that just makes us hopefully a little more efficient. We're going to be short on the number of people to do the job. So how can we use technology to cut through some of those steps that are time-consuming? And, if we can use the electronics to do that and AI to help give us, whether it's putting that data in front of us quicker, it's not to replace people, but it's to replace some of that downtime when you're not able to work with the patients you're there to serve, or the person that you're needing to contact. So I think AI is going to play a big part, but it's again using it efficiently and not letting it rule our world, because it could go astray.
Yeah, and think about how technology and AI are going to kind of inform this next, the upcoming workforce. I mean, being able to map anatomy so Representative Mann can maybe do more per day or whatever. Early diagnosis for medical and mental health issues using those things. Accelerating drug discoveries. I mean, there's so many opportunities, and I'm actually kind of optimistic. AI scares me to death, kind of, on one side, but on the other side, it's super exciting to think about how it's going to impact the workforce and the future delivery of healthcare in Minnesota, for sure. And I hope that we're on the leading edge of that. I hope that we're in front of that, and I hope that we work together, and I hope that government, and this is where we need your help, I hope that we are kind of reminded what our role is, to stay in our lane, do those things that actually assist, but not try to get out in front and try to drive an industry that moves so rapidly right now.
Thank you. I want to move on to the topic that Representative Elkins just mentioned, and that is mental health. And today we were so fortunate to have Sue Abderholden, who's finishing up a terrific career with NAMI, here today with us. And her comments were very spot on and gave a great historical perspective. I've been with the Hospital Association 24 years this November. And when I started, mental health was sort of I don't want to say taboo, but it wasn't talked about at every single healthcare meeting. It was sort of, I don't want to say kept under the carpet, but now every meeting you go to, it's talked about. openly, and it's one of the few issues that I truly believe is one of the most bipartisan issues at the Capitol. And every time Danny and I, my colleague, we go into a legislator's room, they speak to us about a family member, a friend, a neighbor, somebody who has a mental health issue. In 2022 was the first year that we passed a standalone mental health bill. And it had very good bipartisan support, and that bill had about $93 million in it for mental health care. And so the question, this is sort of a different question. I would like to ask you all if you could wave a magic wand. Each of you is the king for the day, and you could wave a magic wand. And Danny, I'm going to start with you. What would you change in our mental health care delivery system? What would you improve? What service line? It can be aimed, this comment can be aimed at us too. This could be aimed at providers. It could be a state initiative or a provider initiative. What could help improve what we're doing?
I love having magic wands. I think I was on a ride-along, and I have, in my community, I have an enormous number of congregate care settings, group homes. And I was just on a ride-along the other day, and it was a person who just got discharged from AMRTC. He was in a group home, and when we got to, he was kind of found on in the middle of Highway 81, drinking, doing the things that people that struggle with mental health issues do. We got to went to the group home, and unfortunately the provider didn't even know he was gone. And so when I think about waving a magic wand for mental health, I think about a massive, broad continuum of care. I don't want mental health delivery, long-term mental health delivery, to be delivered in hospitals. I think there's a psychiatric component to it, along with a psychological component, but I think we're asking our hospitals to do things today that they're not best suited to do. But it's because we haven't built and funded the infrastructure to meet the needs of people that they have today. So waving my magic wand, I would build a broad-based that combines both state-operated services along with county, with IRTS beds, with increased training for providers and provider staff. I would categorize licensure in group homes in step-down facilities to ensure that people with differing levels of need are receiving those services. I would evaluate the heck out of it. I would increase reimbursement rates to make sure that we're paying people to deliver that service. We pay attention to it, and when we find things that don't work, we jettison, and we reappropriate those dollars into things that do.
I think that broad paintbrush probably, your wand covered a lot of our stuff, so good job.
You got to wave it.
You got to wave it. A lot of it is just to expand access, and by that, I'm speaking for myself from the way I see it, but we're so short on facilities, particularly those that need a high-level amount of care. We hear about that from many different angles from our counties that run into the part of don't know what to do with these people, or the fact that they're getting billed excessive amounts of money and how do they cover it. But the fact is we do need to have additional facilities that can handle the high needs patient, where we can get professional help 24/7 for as long as they need it, so that we can get those people back on their feet, and then we just don't push them off the cliff or push them out the door and say, you're fine, go home and live with it. We need to have an off-ramp so that when they come out of there, we're with them every step of the way, because we don't want to have them back as a repeat client or a patient. We want these people to be healthy and productive in our workforce. We just talked about workforce earlier. We need that. We need them out there with us, working and enjoying life. So for me, it's expanding access, which includes the number of facilities we have.
I completely agree with everything that's been said. That continuum of care is so important. And I would also wave my wand to focus on prevention. People don't have to end up in the ER. We don't have to fund more and more crisis interventions, because what we need to do is start thinking about mental health as physical health. They're one and the same, and we can't keep treating them as completely separate entities. The funding for mental health, for reimbursement services, insurance coverage for mental health is lacking significantly in this country and in our state. And so people end up with crisis. Again, which they do not have to. We're going to see now, as people get kicked off Medicaid, that problem is going to increase. Medicaid is the biggest funder of mental health in this country. And so I think the federal government is going to take us several steps backwards, unfortunately. And in the state, we are going to have to try to make up for that somehow. I think, again, the top issues for me, again, would be to combine the two, physical and mental health, and work on prevention.
Well, if you're going to give me a magic wand, it means I don't have to do all the work. So I'm going to get really ambitious and say we need to figure out a way to help all of the people who are living on the street and aren't even well enough to be able to seek out the help.
Okay. Thank you all. Now, so far, we've been getting along really well, okay? And I think our responses have been pretty bipartisan here. So we're going to talk a little bit more now about hospital finances and payment reform. And this is where we might have some slight differences of opinion of what could be done to improve the system. But I have to do a little bit of background here. So as most of you all know, hospitals, like most Medicaid providers, are underpaid in the medical assistance program. Hospitals have been kind of locked in at about 68 cents for a dollar's worth of cost. And so every time we see a Medicaid patient, the hospital is subsidizing that care. And as we heard this morning from James Hereford and Trevor from North, that is getting harder and harder to do as we can no longer cross-subsidize internally as well as we used to, or cost shift as well as we used to be able to the health plans. So making up that gap is getting harder and harder. We also know now that statewide, 64% of our patients are on a government payer, whether that be Medicare or Medicaid. So what I'd like to ask you all to do is kind of two questions here. What can we do as providers to make a better case to the state that these rates need to be increased, number one? But number two, what would you do to reform the payment system? How can we bend the cost curve or increase the payments? Because right now, we're not sure, as that Jenga analogy this morning, we keep pulling things out from the block, and none of us are really quite sure when the Jenga block is going to fall down. So with that, I'm going to start with the doctor on this one, and I'm going to let Senator Mann start this one.
I think anyone who has ever spoken to me for 5 seconds of your life know how I'm going to answer this question. We have spent the last multiple decades trying to make healthcare more affordable in America by increasing the barriers to getting care. So the less people who get care, the cheaper healthcare will be, theoretically. Unfortunately, that's not the case, right? Because people then forego preventative care and middle-level care, and then they reach, again, crisis care, which costs everybody more money. And so despite prior authorizations, inserting networks, inserting co-payers, inserting all these barriers to people getting care, the system is just getting more and more expensive. That, and of course, we have people interjecting themselves all the way along the line of healthcare here, taking money out of the system to the tunes of billions of dollars. We spend more money on healthcare by far than any other country in the entire world, and we do not have the healthcare outcomes to show for it. So it's not that we're providing the best care, we're far from that. And so if I'm going to change the way we pay for healthcare in this country or in this state, I would institute universal healthcare. We are the only ones who don't do it. We have terrible healthcare outcomes, and again, we're paying more money for these bad outcomes by double than other countries are. And so I think at a time when the federal government, again, is going to kick millions of people off of healthcare, where premiums are going to go up by 16, 17% for people on the individual market, and maybe 90,000 Minnesotans are going to see their premiums go up, and maybe another 20,000 are going to be completely priced out of healthcare, we need to start thinking bigger. Because what we are doing is not going to fix this very broken system that we are operating in.
Now, for the Senate sort of counter position, if I may, Senator Utke, how would you like to respond to how you can best help hospitals and reform ideas?
Thank you, Mary. And this whole question, we could bounce all over the page on this one. But the first thing, I will start with the fact that we're talking about Medicaid and Medicare being 64%. So government pay, you're telling us, is 64% of all the reimbursements. It's a unique animal. We're sitting up here because we happen to represent government. But the fact is that we are telling you what you can, what you're going to get paid, and we're the ones paying. That system is just wrong all the way around. The fact that we're holding back and not fulfilling the need, but at the same time, this whole thing needs to be modernized. But government is also coming forward with all the regulations and mandates. We need to have relief along all of those lines, because if we're not going to increase the pay, we've got to reduce the burden somehow. And we could. There's a whole lot of things that are costing our providers a ton of money that's not getting us results as far as health related. And the other one I had thrown notes on was, tort reform. How much do we pay for liability insurance just because of that versus if we had some regulation there? And how do we get to the bottom of this? To me, it's just transparency from both sides. And we just need to be able to sit down around the table and really share ideas to come up with a solution. And too many times from the legislative side at the end of the session, I see more mandates being pushed out, and we didn't have really any input from the provider side or the payer side. So, we could go on forever here. I've got a lot of concerns with our current system. But Senator Mann, I just won't follow you down the road of your idea there. So, thank you.
So, Representative Elkins.
So, I would say, obviously the current situation is demographically untenable. As the population continues to age, and with age becomes sicker, we're going to have increasing shifts of payment coming from higher paying commercial plans to lower paying government plans, where the rural hospital systems in particular are being killed by that demographic mix. So you could say that, well, part of the answer is just going to have to say that the government is going to have to pay higher rates on its share. I don't think we don't have a lot of money laying around to do that. So I'm going to, the one provocative thing I'm going to say is I'm going to turn this back on the hospitals and say, you guys need to understand your cost structures better. Hardly any hospital systems conduct any kind of managerial cost accounting. When a hospital like Gunderson in southwest Wisconsin does so, it makes the national news. But I think before you guys come to us and say, you got to do something about the cross subsidy between commercial and government programs, you need to first better understand your own cost structures, because the prices you're charging in the marketplace right now make no sense whatsoever. So one of my signature accomplishments so far is to make all the hospitals publish their prices in a consistent format so that organizations like Turquoise Health can suck them up and create price comparisons. Go out to Turquoise Health and just put in your zip code and something like hip replacement or MRI, and compare the prices that you're all charging depending on the health plan and the site. there is absolutely no rhyme or reason whatsoever for what you guys are costing for it. So I am a big fan of Uwe Reinhardt, who famously remarked that it's the price is stupid, and it is the price is stupid. So go back and look at your prices, understand your cost structures. Okay, so when hospital systems do engage in managerial cost accounting, they find ways to cut their costs.
And I do have to just make one little comment, okay? So 50% of every dollar that's spent on healthcare is not going to providers. It's going to middlemen and pharmaceutical companies, for-profit vendors, whether that be our electronic health records, et cetera. So I'm always fascinated that everybody wants to focus on the 50% that is the providers who are actually touching the patient versus the 50% on the other side of the equation. But with that, I'm going to turn it over to Representative Nadeau.
Thank you. If this were simple, we wouldn't be here. If healthcare wasn't about massive amounts of money, we wouldn't have the problems that we have today. I get in trouble all the time. When I talk about healthcare, it's all about money. We can move to a universal healthcare system, and I would never want my senator over here to make only $150,000 a year doing the work that she does. But, every country that's gone in that direction has been, access has decreased, quality has decreased, and that's, and maybe it doesn't have to happen in America. Maybe we're smarter than everybody else. And I think everyone here is willing to look at this for the most part, because I'm reminded of when we get into these very, very foundational difference debates, I always think about Abraham Lincoln in his first inaugural address when he said that we're not enemies, we're friends. We can't be enemies, and we can't let our passions, limit our ability to continue to, have an affection for one another. So these are challenging things. Hennepin Healthcare, which is where I spend a lot of my time, our pay mix is up almost at 70% public programs. The state legislature, the state government, doesn't fund the cost of care for patients in our public programs. It just doesn't. And it's not, we all know it. It's all there. We could prioritize it, but we don't. We removed a chiropractic benefit set from Medicaid this year. We tweak around the edges. We try to manage these things, and at the same time, we also have to balance giving away, free e-bikes that are far seemingly more important than funding our healthcare system. Now, we can prioritize this and we can solve this, but it's going to be hard. And it's easy to sit up here today, and I will stand right alongside Senator Mann and anybody else and go after the federal government for what they're doing right now with Medicaid. It's putting us in a very, very difficult position. But at the same time, we have to make some very, very difficult choices. I got on MNsure this morning because I just wanted to know, and I just typed in the basic stuff that you can do to get an average, cost for the individual market. I typed in for, a 60-year-old male, and then I went and it was $500, and it was around $7,000 to $8,000 deductible, about $9,000 out-of-pocket max, and it was between $600 and $725 a month premium. And then I went on healthcare.gov and I checked Madison. Same exact thing. It was between $348 and $510. All right? So where are the differences? Minnesota, we have the highest MA per enrollee cost in the country, in the absolute country. No one's higher than us. We've taken every optional benefit set, which is great. We made those decisions at the time, and I'm not questioning the validity of those decisions, but times have changed. We need to look in at utilization data. We need to determine what we should cover, what we shouldn't. Maybe we should have benefit sets for adolescents and young adults, and we don't have them for seniors. Maybe vice versa, whatever. but industry has to drive those things. If you let us decide all these things, I think we're in trouble. At least if you let me decide, we're in trouble. But I think we do need to find a way to work together. Are there concepts? Are there pieces? I mean, look at our reinsurance program. In 2024, this is high claims payment. In 2024, there was 5,715 patients. They consumed $261 million of healthcare services. Is there a possibility that we could target that group and start looking at, wait a second, is there a better way for us to provide wraparound, surround services, stable housing, connections, case management, intensive things for a population that's consuming that kind of money? And can the state do it on its own? Absolutely not. We have to partner with our social service delivery systems. We have to, but we also have to trust one another. We can't play politics with this anymore. There's too much at risk. Sorry.
Thank you. That was actually a very good panel, so good discussion. And I still love you, even though you made that comment, okay? So many of you guys know that I am from West Virginia, okay? And we have a saying in West Virginia. It's called the canary in the coal mine. And literally, the coal miners would take canaries into the coal mine, and if the canaries dropped dead, it meant there wasn't enough oxygen in the coal mines. So Representative Elkins mentioned what's going on now in rural health care, and I'm sure many of you all have seen the numbers, but 700 hospitals nationwide, 1/3 of our rural hospitals are at risk of closure. The article goes on to say that 360 of these hospitals are at risk for immediate closure. So this is more than just trying to get money into the Medicaid rate, you all. This is, what do we do to keep our rural health care sustainable? We're hearing more and more from our members who are struggling with, can they keep their OB services open? Can they keep their mental health services open? What are they going to do? And so I'd like for us to just take a minute. It's kind of like the last question a little bit, but I'm really trying to zero in. What can we do to help keep healthcare services local? We hear that over and over again. Keep healthcare services local. So I'll start back with Steve, and we'll go back this way.
This is the hardest one. I don't know, honestly. I mean, you've got this rate base that's deteriorating as the rural population ages. With the cost continuing to increase, the economics just aren't penciling out. So something's got to give, and either we have to raise our compensation rates, do the things that Danny's talking about. It was a great answer, by the way. To figure out how to deliver the services more, comprehensively and efficiently. Another great quote recently is that primary care is an investment. Everything else is a cost. In other words, we need to, make sure that people are getting the preventative care that they need up front, so that we don't run into having $1 million patients in the reinsurance pool. Just head off those kind of catastrophic things by providing better primary care, more comprehensive primary care up front.
Yeah, I agree. Looking at things from a more holistic view, right? How can we keep people from using healthcare by offering things like paid leave programs where people can take time off to take care of themselves and not lose their jobs? Again, talking about mental health as in the same vein as physical health, but particularly in rural healthcare, the one thing that I've been looking at recently is that moratorium on beds. We are seeing hospitals close, and then some hospitals are left to pick up the pieces, and they need to be able to expand if possible, and that's becoming difficult, so we need to look at that. But again, I think with the cuts to Medicaid that are coming, we are going to be in really big trouble. When someone says 700 hospitals are at a risk of closing, I think we can all fairly safely say that the system isn't working as it currently is structured.
Coming from rural Minnesota, our critical access hospitals are extremely important. I came in here awfully quick, so I only got a chance to see one of our local hospitals. There's probably others here too, so we appreciate everything they do up in our district and our region of the state. They do a tremendous job, but we need to, and when I say we, it's government, how can we make their job a little easier? And part of that to me is taking off, there are a lot of burdensome regulations and mandates that have been dropped on them over the years. We need to make their life easier and better so that they can do what they want to do and do best, and that's to serve our local citizens and provide the health care they're after. And one thing with our federal partners right now that it's on the table, and Minnesota have checked on it. It's an application that's going in, but that's the Rural Health Transformation Program. That's $50 billion to be spread over our rural areas across all of the 50 states, and just hopefully making sure that our rural providers have equal access to this additional funding to help keep their doors open and help provide those services. We've seen services get reduced, and it's not because they want to, it's because the bottom line says we have to do that to stay viable. So, I'm just hoping that a combination of some additional dollars coming in and, we in the state need to make their life easier. And I think together we can help move the needle a lot on this. So I'm optimistic, but let's see what happens.
And I agree with all of those. And I think last year we enhanced telehealth using technology to ensure that we've got better access, not just in rural Minnesota, but creating that system-wide capacity for in-person patients. But I think the regulatory component, and I'll use an example that we had last year. It was a little hospital in Ely, and I don't know if anybody's here from Ely, but yay, thank you. We had, it was swing beds. I mean, we had to pass special legislation for swing beds up in Ely. We need to be far more accommodating to the individual needs of the regions in the state. The challenges that we face in Hennepin are far, far different than what's faced in Cottonwood County. The populations are different, demographics are different, expectations are different, perceptions are different, quality of care is different. And for us to sit down in St. Paul and say we need to have, this one-size-fits-all, I think we need to do a better job of listening. We need to do a better job of trying to accommodate those needs. We passed a bill this year that basically gave county-based purchasers a monopoly in the regions that they're in. That was kind of weird for me. That was weird by basically, prohibiting our other plans from competing in those areas. But you know what? It passed. We did it, and it's important for us now to evaluate it and let's see if it increases care. Let's see if it decreases costs. Let's see if it uses some of those revenues to work on, preventative care that we all know drives long-term cost care down.
This is my last question, and it's going to be pretty open-ended, and I'm just going to start you all off with a couple comments. So, healthcare is obviously highly personal, and at every point, everybody at some point in their life is going to encounter the healthcare system, either for themselves or their loved ones. And I've been thinking about costs, and part of our challenge is that healthcare is both high-tech and high-touch. So many sectors of our economy are more technologically based, and many are more high-touch, but healthcare, we have to be both high-tech and high-touch. And this year, I was struck by the fact that Medicare and Medicaid are now celebrating their 60th year, 1965. And the Medicaid program now has about 71 million enrollees, and Medicare about 68 million. It's the first time recently that Medicaid has now surpassed Medicare in terms of enrollees. This has become the safety net for millions of people, particularly our Medicare seniors, who used to, prior to 1965, were in poverty when they had a health care expense. So I just would kind of like to ask you for reflections on what we can do. All of us here in the room care about health care. That's why we're here. So what can we do to build support for Medicare and Medicaid? And I know you all have differences of opinion on what's happening in Washington, but fundamentally, I know you all care about Medicare and Medicaid. So what advice would you have for us? Senator Utke, I haven't picked on you first.
All righty, thank you. You know, they're kind of two different animals. Medicare ends up being, when you reach the age I'm at, it becomes part of your life, and you sign up and you become part of that pool. The Medicaid covers typically the full gamut, particularly a lot of times starting with our young children, but then up through some of our working age, and again comes in and for the elderly for various types of care. To me, I want to figure out how we can reduce the dependence on Medicaid. We saw what happened with COVID. Medicaid got ramped up all across our country, some states more so than others. And we got to figure out how to get back down some, just because we can't afford it. And the other thing is, usually those people are probably either out of work, not working, or have a very limited working life. And it goes back to, I always tell people, a paycheck equals quality of life. And I want to do what we can to help those people that are dependent on government services that are able to work. Now, some of them on there, they're not able to work, and I fully understand. We're going to have Medicaid for them throughout the years they need it. But to get those that, whether it's additional training, some education, however we can get them out into the workforce and be a productive citizen there, because it goes back to, we want their life to have quality. And to me, once you've got the paycheck, you're supporting yourself, you're buying your own things. I was just down, spent the morning in Rochester at the food bank and food shelf. Kind of that same thing. Those things in a lot of cases are supposed to be stepping stones. Working poor, how do we get them, get them through the tough times, but how can we get them out to where they're self-supporting again? Some of Medicaid follows that same direction.
Thank you. Representative Elkins.
So once you reach 65, you realize how liberating that is, actually. I'm a member of a Medicare Advantage plan. It's a really good deal. Don't expect it to be anywhere near as good a deal next year. In my ideal world, if I could, wave a magic wand, we would all pay for our health care through our taxes, not through our employers, which would be liberating for everybody, not just me. We would, instead of the commercial market, cross-subsidizing everything else, the burden would be evenly spread, and we wouldn't have to worry about commercial versus government payment mix. We would have somewhat more rational pricing than we have right now. If magic wand time, I think we should be paying for our health care through our taxes, not through payroll deduction, and there should be a lot more uniformity in the rates that are paid.
Thank you. Representative Nadeau.
Thank you. That's an interesting question, because we're talking about, who's paying. And that's a lot about what our healthcare discussions always, surround. Who's going to pay? And so I think Representative Elkins brings up an interesting point. There's always the other side of that is then how does that care be delivered? How is it being held accountable? And I'm with Senator Utke in that, the current administration is making a lot of changes to our Medicaid program, but I think in general what they're trying to do is focus and make sure that our Medicaid system is kind of pushed back to what it was supposed to be. It was a bounce safety net. Have we let, people with long-term disabilities, and I will be the first one to say that there shouldn't be 6-month reviews on people with long-term disabilities. It's ridiculous. It's going to cost us a boatload of money. But we have to measure those things. We should provide that safety net for, people where they are, and then provide that way out. And then as far as, who pays, that's where our partners come in. It's the state, it's the feds, it's the managed care organizations, it's our PBMs, it's our drug manufacturers, it's rebates, and then, that's what makes it so complicated. So to answer your question, I don't know how we encourage support for these programs. It's a component of our healthcare system, and I think we all support it because it's part of our system. That's just what it is.
And I purposely let the final word go to our physician senator here today.
Thank you. I have 4 seconds here.
Go over.
Medicaid and Medicare were never perfect, and then we privatized it, and it really became imperfect. And it was supposed to be a safety net, like was mentioned, but now it's mainstream coverage. The vast majority of children, for example, have Medicaid in this country. We can certainly say we should make people work more, but the vast majority of people on Medicaid already work. The issue is, for the last 30 years, we have been shifting the wealth in this country from the middle class to the top 1%. The top 10% wealthiest people in this country run 60% of the economy. That's why more and more people require government-run health insurance, because more and more people cannot afford health insurance, period. And so we have to have a much broader discussion about why this is happening in the first place. When we have people working for poverty wages, 50% of the population working for poverty wages, while CEOs are making billions of dollars, and then the government has to subsidize their workers because they're not being paid properly, that's a problem. We're not going to fix healthcare until we touch upon all those topics as well.
So you all, are these terrific legislators? Come on, they are, okay? So I want to thank each of you all for coming today, and I thought that this was really a pretty good discussion, and I know there's a lot more work ahead, but I know each of you all is willing to work on reform, and I know each of you all is willing to embrace change, and thank you for being here with us today.
Again, that's Minnesota Hospital Association Vice President of Government Affairs, Mary Krinkie. I'm Tim Nelson, and you've been listening to Hospital Matters from the Minnesota Hospital Association. Join us next time for another look at issues impacting hospitals, health systems, and patient care in Minnesota. Thanks for listening.